Okay, so thank you everyone for coming. Welcome. This is our April lecture in the Wolfson Centre lecture series. My name is Lucy Riglin. I'm a lecturer at the Wolfson Centre and I'm going to be introducing our speaker today. Just a few things to note before we get started. So first is that this is a public lecture, so it's being recorded and it will be posted on YouTube, where you'll be able to also see our other talks in this series that you may have missed. Please make sure that you're signed up to the Wolfson mailing list if you'd like to be kept informed about these and other upcoming Wolfson events. These include the next in this lecture series, which is going to be by Professor Vikram Patel on the Thursday, the 16th of May, where he's going to be discussing school interventions for promoting adolescent mental health with a case study from India. And there's also going to be the next session in our biannual Wolfson Clinical Spotlight series, which is aimed at practitioners working in the field of youth mental health. That's going to be on Wednesday, the 26th of June, and will feature Professor Kathy Creswell, who's going to be discussing increasing access to psychological treatments for child anxiety problems. And finally, just a reminder that this session is an hour. It's going to finish at 3 p.m. Questions and discussions are encouraged after we've had the talk. So please post your questions via the Q&A box, which you should be able to see at the bottom of your Zoom screen. So now it's my pleasure to introduce our speaker today, Professor Argyris Stringaris, who is a clinician and a neuroscientist. He is the chair of the Child and Adolescent Psychiatry at University College London, where he co-directs the Anxiety, Self-Image and Mood Lab. And he's one of the pro-vice provosts there who's co-leading the grand challenges for mental health and well-being. He's also a professor of child and adolescent psychiatry at the University of Athens in Greece. So Professor Stringaris's research includes both basic research, which focuses on how affective phenomena are generated and maintained, as well as clinical research, which looks at interventions that reduce the negative impact that affective phenomena have on young people and families. So I'm sure that his talk today on fundamental problems in the evidence base of adolescent depression treatment will be of great interest to those of us who are interested in understanding and improving young people's mental health. And we thank him very much for coming to speak with us today. So without further ado, over to you, Professor Stringaris.
Thank you very much, Dr. Riggin, for the very kind introduction and the invitation. It's a great honor to be presenting to this audience. I'm going to share my screen, so give me a second. We have already rehearsed this, but it doesn't mean that it will work. Let me see. Can you see my screen?
I can see your screen.
Okay, great. So okay, great. So yes, I'm going to be talking about some fundamental problems with the evidence base of treatment of actually youth depression, child and adolescent depression. And it's something that has been preoccupying me for years as a practicing clinician, but I've only recently had the chance to kind of think a bit more through it. This is a paper we're writing at the moment, and I'm writing this together with my good colleague and co-lab and clinic leader, Dr. Georgina Krebs here at UCL, and a number of other great people have the opportunity to work together with. So this is an overview of my talk, and I don't want to tax your working memory. I'm going to be presenting these points, but the first thing that I want to do is just ask the question, which is how to decide between psychotherapy, which is one treatment modality for depression in youth, and medication, then introduce a conceptual framework for this decision making. And this is, I think, that arguably one of the most important bits, understanding what we mean by comparing and how do we make a choice. And then I'm going to go into the particular questions that arise after we, have set up this conceptual framework. So how to decide between psychotherapy and medication? So as all of you, I'm sure, will know, there are two principal treatment modalities for adolescent and child depression: psychotherapy, medication, and then there's a third one, which is both. So how do you choose between them? TMS is not yet, transcranial magnetic stimulation is not yet an approved treatment. So we're just sticking with that. How do you choose between them? Where do you turn to find the evidence that will inform, as a clinician, your treatment options? And where does a child, patient themselves, family, turn to for such information? And the answer is primarily to the national guidelines. And we're very lucky in this country to have such an institution as is NICE, the National Institute of Clinical Excellence. It's amazing, and it's something that around the world has impact around the world, and it's, as you know, been used across medicine to develop guidance on all sorts of ailments, and also for depression. So we turn to that primarily. We also would turn to meta-analyses, which is what is feeding into the NICE guidelines, both kind of the regular kind of meta-analyses that's, we're all familiar with, but also network meta-analyses, which are meta-analyses where you can compare treatments that haven't been compared directly with each other. So suppose you have compared treatment A to B, and treatment B and C have also been compared, then under certain assumptions, and these assumptions are very important, and I'm going to be talking about them in a minute, under certain assumptions, particularly the one about transitivity, you could compare A and C with each other. So that's what a network meta-analysis is doing. Okay, so that's where we turn to for advice. And if you look at the NICE guidelines, NICE basically tells you what? It tells you do psychotherapy, and if that fails, do psychotherapy, and if that fails, do psychotherapy, and if that fails, well, do psychotherapy, and maybe add some medication. That's kind of roughly it. And so there is clearly a primacy for psychotherapy across all levels. Because I'm aware of the audience that I'm talking to, and I know that so many of you there are world experts in depression. I obviously didn't, reproduce the NICE guidelines here because you're going to be very familiar with them, nor did I, repeat what you all know about the importance of depression as a public health problem. But it's, it's very obvious to all of us, right? But now let's see what NICE says. It says psychotherapy, and it's very skeptical about medication, and that's kind of, that's kind of understandable in a way. A top quality meta-analysis by Andrea Cipriani that was done in 2016 showed that, fluoxetine just about differentiated from placebo, and that was the only drug of the ones they tested, of the ones that had RCTs back then, that differentiated. And please humor me. I'm going to be showing you some numbers and formalisms, but I'm going to be going through them very slowly. So this is the standardized mean difference, like it's a Cohen's d essentially. You can, 0.51 is kind of a medium effect size, one would say, using this rule of thumb. For standardized mean differences, half a standard deviation essentially. So one might say, oh well, it's not too bad, and yeah, maybe not too bad. But notice the confidence interval, right, which stretches from essentially -1 to 0, right? So the interpretation of a confidence interval, just to jog your memory, is a frequent interpretation, at least, is if you repeated this experiment, as the statisticians would call it, 100 times, 95% of the time, the true value would fall within that interval, right? So in other words, it could be very close to 0, right? Or it could be very close to a pretty large effect size. So there's a huge amount of uncertainty, despite the relatively, large number of trials and patients we have seen. So, and that's fluoxetine. So it's really, not that great. And remember, all the other ones didn't differentiate from placebo, right? Certainly didn't differentiate from placebo. Escitalopram, citalopram in that meta-analysis. So why then really not give everybody just psychological therapies, right? And this is many of you will be familiar with Pim Kuiper's work. He's one of the world's most renowned meta-analysts for psychological therapies, particularly for depression. This is one from 2023, where he basically says, you know, psychological therapies work actually great. And if you look at this bit here, you know, this is relative risks. You can transform this to standardized mean differences. You know, it's pretty big, you know, and a pretty robust finding according to this meta-analysis. And you see that some studies have quite extraordinary effect sizes of 2, 2.5, and so on and so forth. So they differentiate very well from whatever has been used, and I'll come back to that, in psychological controls. So if you compare the effect sizes of psychological therapies to those of medication in that way, well, then you would go for psychological therapies, of course. But then there's a network meta-analysis, which is what I told you before, right? It compares treatments with each other using both direct head-to-head comparisons and indirect, and that's a big contribution, right? That it can do a thing as if these treatments were there. These comparisons were there, sorry. So say you have venlafaxine, which you have compared to fluoxetine, but you haven't compared it to CBT. But because fluoxetine has been compared to CBT, then you could do a comparison under certain assumptions of venlafaxine, say, with CBT. That's an example plucked out of thin air, right? And indeed, I forgot the second time I do this, to put the name of the authors down here. I'm really sorry. It is in the paper, obviously, and I'm very happy to add it afterwards to the slides. Sorry about that. Only fluoxetine, the main finding of this meta-analysis, only fluoxetine alone and fluoxetine administered together with CBT were significantly more effective than pill placebo or psychological controls. I'm going to read this out again. Only fluoxetine alone and fluoxetine administered together with CBT were significantly more effective than pill placebo or psychological controls. So CBT on its own isn't. IPT isn't. Family therapy isn't. Psychodynamic therapy isn't, according to this network meta-analysis. So, but yet, the NICE guidelines say, oh, you should be doing psychotherapy and psychotherapy. That creates a problem. So why is that? What's going on? It's confusing. So imagine you're a parent, you know, should I expose my child to medication or stick with CBT or whatever other psychotherapy? As a young person, you would say, why should I even take medication? And as a clinician, you would say, as I have done for some time, well, it's all confusing. Why is it like that? And as a policymaker, one who's tasked with apportioning funds to clinics and to researchers, you say, you know, should I fund the expansion of psychological treatments? So let me introduce a conceptual framework for decision making. And there are, in my mind at least, 3 important elements. First, are the populations in which each treatment has been conducted comparable? So as I will show you in some formalisms, whenever we do a treatment trial, unless we treat the whole nation, we have a sample, right? And that sample comes from a population. So are the samples coming from the same population? Second, are the control conditions similar? Are psychological controls as efficacious as placebo? And thirdly, what are psychological controls? Are they plausible controls? So I'm going to go through them step by step. So are the population in which treatments have been conducted comparable? Don't be put off by the formalisms. It's very simple. If people entering psychotherapy trials are systematically different to those in medication trials, then comparisons are going to be wrong, right? And it may even make it impossible, but I'm not going to fall on my sword for this one. It's a big discussion. To conduct network meta-analysis, because the so-called transitivity assumption is probably violated. Formally expressed, the sample average treatment effect for each is looks like this. You have a treatment effect for psychotherapy and a treatment effect for medication. And what you want to make sure is that this sample and this sample, that they really come from the same population P. Okay, both trials sample from the same population P. Well, it is very unlikely for it to be the case, because we know that people have preferences, or many people have preferences in terms of whether they want a psychotherapy or medication. It seems like in this country, and I'm sure this will speak to your experience as well, at least in the clinics, that British parents for sure often prefer psychotherapy. And that's the orthodoxy in this country. Psychological therapy first, or psychological therapy, that's it. And there are papers that state that not only are there preferences, but those preferences correlate with characteristics of the individuals who express them, be it patients or parents, right? So characteristics such as the severity of depression or the gender. So in total, what we did was we reviewed the existing studies and said, okay, let's go back to the RCTs, and we found 81 RCTs, 28 active arms, so medication in this case arms, and 25 control, i.e. placebo arms of antidepressant trials. And the numbers you see there for active arms, i.e. CBT, IPT, or whatever it was, and control arms, which could be active control or some sort of proper control, or we'll talk about whether it's proper or not, or wait list or treatment as usual for psychotherapy trials. Okay, and we asked the question, are people in psychotherapy trials similar to those in medication trials? I.e., is this assumption of them coming from one and the same population justified? We looked at 3 things. We would have liked to look at 103 things, but we don't, they're not available. So this information is pretty much nearly universally available, like the severity of depression at baseline, % women, and age. For those of you interested in the technical aspects, in order to be able to compare across studies, because they've used different outcome instruments, we had to adjust everything to the range, and I can show you the formalisms for that. But basically, we have a common language for what severity is. So this is however you measure your baseline severity and your outcome. Like it could be a children's depression rating scale revised, the CDRS, it could be the BDI, it could be the HAM-D, it could be some other measure, the MFQ. This is % women, that's self-explanatory, and the same thing with age here, right? So, and what we find is that those in psychotherapy trials are quite a lot less severe than those with medication. We're talking about 7 points, I think, on the CDRS. That's how this translates, this difference translates. And I think that's what we got also when we just focused on the CDRS. I'm using the CDRS because it's standard, it's the standard, certainly in pharmacological trials, and people often have an intuition of that. But you see, it's not an insubstantial difference. The confidence intervals kind of overlap very little. In terms of % women, many more women, about 9%, more than 9% more women in the psychotherapy trials compared to the medication trials. And the age was similar, even if those in psychotherapy tended to be slightly bit older, but not at the pre-specified difference level. So there's a fair degree of overlap of the confidence intervals. So yeah, so here you see what I was saying before about the CDRS for medication studies, which would translate to about 50, I exaggerated a little bit, 51.6 for psychotherapy versus 57.3 for medication as equivalent scores on the CDRS. So, a substantial difference in severity. There was another thing that we looked at, which is the number of sites for psychotherapy and medication trials. Now, and this is the medication trials, and you can see that many medication trials have more than 20 sites participating, whereas this doesn't happen at all. There's hardly any with more than 10 sites, and there's many with 0 sites. with one site only, not zero, for the psychotherapy trials. And why is this important? Because we know from previous work that the number of sites, of study sites, is related to the placebo response. We can't know for sure why this is, but when you have many sites, the oversight over phenotyping may not be as good. The primary unit of reimbursement is recruitment. So there may be perverse incentives that arise, but it's kind of an empirical fact. So again, this makes it hard to claim that the people in psychotherapy trials are the same and that the design of the psychotherapy and medication trials is comparable. This last point pertains to the comparison of sites. So quite some substantial differences, making us worried that these are different things that we're comparing. The next bit, and the one that I was most struck by, is whether the control conditions are similar. So are psychological controls as efficacious as is placebo? Just to remind you what the standardized mean difference is, the difference between, a treatment, a control, or two drugs or whatever, divided by the standard deviation. And it's a great sin that we all at some point in our lives have unfortunately committed, which is to compare SMDs, to compare standardized mean differences or effect sizes blind to the raw data. So look at this scenario. You have the mean of the treatment A being 0.8 and the mean of the treatment B being 0.6, or a mean of B could be placebo, for example, and have a standard deviation, say, of 1. Your standardized mean difference would be 0.2, right? Now, look at this scenario where your mean of the treatment A is 0.2 and mean of treatment B, or placebo, whatever you want the other treatment to be, is 0 with the same standard deviation. Again, you have a 0.2 here, right? You have a standardized mean difference of 0.2. So this standardized mean difference and this standardized mean difference is the same. But is it the same, really? I mean, would you tell anyone, oh, well, you could take this treatment or this treatment, it doesn't really matter. Well, obviously, we'll want to give someone a treatment where they have a much higher probability of responding than they would have here, right? So it's wrong to just look at standardized mean differences or any effect size out of context. We've written a paper about this last year that was published in JCPP as an editorial perspective, where we make this point more generally, particularly about so-called small effect sizes. So one shouldn't be doing that, obviously, and we didn't do that, and we went back and looked at each arm. So let me walk you through this figure because this is quite, I think, an important one. So what I'm showing you here, this line here, this dotted line, is the line of no effect, the 0. If anything bumps into this line or crosses it, it's at that point stops being important, right? Stops having an effect, all right? On the x-axis are standardized mean differences, what I showed you before, with their 95% confidence intervals. The more you go to this direction, right, the less effective you are until you get to the line of no effect. The more one goes to this direction, the more effective they are. Okay, so the more you go to the left, the more effective. The more you go to the right, the less effective. Okay, and I have here 4 treatments, or rather 2 pairs of treatments. In the kind of reddish pinkish ones are medication, and I have the active arm, i.e. the drug here, and here's the control. And what I'm depicting, these standardized mean differences are within trial standardized mean differences, within individual, that is, within arm. So this is a pretty big standardized mean difference of -2. So from the beginning of the trial, from the baseline to the outcome, this is the standardized mean difference, pretty massive, right? But the thing is that the same ish happens for medication control, for placebo. You also have a pretty massive response to it, and you can see that the two hardly differentiate from each other. Okay, but you see where they are. Look at the lower bound of the confidence interval here. All these, just to remind you if I didn't say it clearly enough, are results that we have that come from a meta-analysis of studies that I showed you before. Now, this is a psychotherapy active, say the people who got CBT or IPT or family therapy or psychotherapy of some other sort, for example, psychodynamic psychotherapy. This is the standardized mean difference, is 1.2 nearly. It's also quite big, actually. Again, it's within subjects. It's much smaller than what you see here for medication active, and even smaller than medication control. And this is the controls for psychotherapy. And they are extraordinarily weak when compared to the medication control, which is placebo, right? So see what this treatment is compared to. It's compared to with this treatment, which has a big efficacy, right? Whatever, has a big standardized mean difference. And look what this is compared to something which is pretty weak, right? So, and these are the actual numbers here with the confidence intervals. So basically exactly what I've shown you here. We've done this in a number of different ways. So this is now showing, I've showed you all the trials before. Now I'm showing you only those for CBT, fluoxetine, and citalopram, because these are the FDA approved medications, and CBT is kind of the one psychotherapy with most of the evidence base in its favor. This is now excluding wait lists. And as you can see, nothing changes. Like if I showed you these three graphs, you wouldn't see a difference, right? You wouldn't discern a difference that easily. And this is with all subclinical depression studies excluded. And again, it looks very, very similar. Okay. So what this tells you is we are comparing things that have very different, that are very different in both probably the populations that the samples are being drawn from, but also in terms of, the control groups here. Now, it is very naughty of us to have taken each arm out of its randomization. And if there are network meta-analysts amongst you, they will say, oh, you can't, you really can't do that. But yes, it's true. We can't do that if our inference is that, say, this is more efficacious than that. But that's not necessarily the inference that I want to draw. It may or may not be. It may just also be that the people who went into this trial are fundamentally different to people who went into this trial. My point for doing this is not to convince you that medication active is more active than is better than psychotherapy active. It's an important question, but just to show you how different these are, and particularly how different these controls are. And that says quite a lot about whether we can compare them in the first place or not, right? Now, let's say, okay, well, let's move away from that. What are psychological controls? Are they plausible controls? So if you're, just again, using common sense, right? Why do we have controls? Let's just think about it. Why do we have controls in trials? Well, controls are meant to create what the philosophers call, and the philosophers of science in particular, and the causal inferences, a counterfactual. What would be the outcome had there been no treatment? Okay, and this is the approach that brings us closer to causal inference. And the main reason we do RCTs, if the control is adequate, then the rates of spontaneous remission, regression to the mean, etc., are controlled for, and confounders are also dealt with because of the randomization, as you all well know. But the key here is to create a good counterfactual. Now you will say, well, if it's all about what would happen had there not been a treatment, then you just treat some people and you don't treat the other people. Well, it's not quite like that. Because if you randomize people and you say, I'm going to randomize you to getting the treatment or to not getting the treatment, well, if you tell someone you're not, if you tell them, oh, you've been randomized to no treatment, well, that's clearly not how you would have been had there not been treatment. It's how you are when you don't have a treatment, and you're also being told that you're very unlucky and you're not going to get a treatment. And that's what happens when you are in treatment as usual. You're not going to get this treatment at least, or in waitlist control. So it's a punitive condition in a way, right? It's bad. Oh, I'm not going to get it, right? Okay. So, or the situation where you basically get a second-rate treatment, like, oh well, you haven't been randomized to the good drug or the good psychotherapy, you're going to get, something that, probably maybe should be perhaps work. I'm not sure. Like, how would you like that? What would your expectation be? So we create counterfactuals. We should strive to creating counterfactuals that are plausible, right? And control for this expectation effect. And the placebo under ideal conditions, and they often don't work. For example, I don't think in ketamine that we have a good control, because we don't have anything that creates the dissociative effects in quite the same way as ketamine does. But with fluoxetine and maybe some other drugs, it may be more plausible the placebo does what it does, and creates similar expectancy effects. So how is it like with psychotherapy? Well, it's not great actually, because more than 50% of psychotherapy controls are waitlist or treatment as usual, and that's not great, because these are not good counterfactuals. You're being told after you've been randomized that you've lost out on the good treatment, at least for the moment. So your expectations are going to be different. So it's an unfair comparison. But what about active psychotherapy controls? Because there are those as well. Okay, I'm sorry, this may be a bit small. I don't know whether you can see it. So what we did was, if you just listen to me, I hope it will become clear. What we said was, well, if you get placebo, the point about placebo is any one of you who has ever administered placebo will know how much effort goes from pharmacists to make the placebo look exactly like the active drug. And the pharmacists sit there and, work their magic on the pills to look exactly the same, taste, smell exactly the same. So in human equivalence, it should be something like, well, if it is the psychotherapy doing the job rather than some non-specific effects, then if I'm going to have, I don't know, an hour a week with a psychotherapist, then I should also have 1 hour a week with a psychotherapist. But in the one case, I should do psychotherapy. In the other case, do something else. I know it's demanding, but all sorts of things are demanding and not that easy. But that should be the basic. And if it can't be a psychotherapist, well, it should be someone who's at least as nice, right? And the number of sessions, the frequency of the sessions, the length of the sessions, and the total hours that you've seen someone should at least be the same, right? And so we looked at those things and we said, what about number of sessions? Well, in the active arms, the number of sessions amounted to about 14. In the control arm, it was 8. It's about double. In terms of frequency, it's also about double in terms of frequency per week. In terms of session length, again, nearly double, right? This is now minutes per session. And total intervention hours, it's also about half, right? It's only the total intervention period that is similar. So all these are, as you can see here, statistically significant and what have you, except for the total intervention period, which we didn't expect there would be difference. So I mean, these are not fair controls, I don't think, by any account. And this is on top of the fact that psychotherapy controls are not, that there's no blinding. Okay, that may be very difficult to do. It may even be insurmountable. It depends. But that kind of fundamental stuff isn't there, which is really bad, I think. So what we need to improve, how do we need to improve the evidence base? So be clear about how much we don't know, actually. And there's quite a lot that we don't know. Do head-to-head comparisons, as in other areas of medicine, and we need to think about who enters such trials. And in some cases, it may be impossible to get anyone who really wants to do psychotherapy to do a medication trial, and maybe even vice versa. So in that case, even the head-to-head comparisons will draw from a very particular population, i.e. those people who are prepared to get either. But that's fine. But one has to be mindful of the inferences they draw. We may need to use naturalistic comparisons by employing things like physician preference designs. And at Cardiff, there are people who are amazing causal modelers. I had been, before this presentation, rereading Professor Thapar's chapter in the New Writer textbook on causal inference. So physician preference is one of them, one of the designs that one could use. So if we had situations where clinics had a preference as to whether they prescribe medication or psychotherapy, but they were similar or equal in all other respects, then we have a quasi-randomization that we could use. Improved psychological therapy controls. I think this is quite an urgent call. So I think there's a lot of work to be done there. And there are some good examples actually in psychology. I think in some of the anxiety disorders, particularly social anxiety disorder, social phobia, there's, quite good examples of controls, like they compared cognitive therapy to, behavioral therapy, which I think, that to me is a fair control. I would change the guidelines, to be honest. Like, if I'm right in what I told you today, then, I think the guidelines are, they're really not clear about the state of the evidence, to put it mildly. And then we need to develop a decision science around how patients choose between treatments. At the moment, people choose between treatments because they're influenced by, obviously, the press and the guidelines and all that. But I think there's quite a lot that needs to be done about understanding what each choice entails. We've written, some of you may have seen those papers. Lucy Folks and I, with some colleagues, have written some papers recently about issues with school-based interventions and the fact that harms from school-based interventions can scale. And one of the things in our latest paper that was published last month, I believe, we are also argued that the potential harm comes from opportunity cost, or what you could be doing had you not been doing 1 or 2 hours per week of, say, psychotherapy. So that needs to be factored in, and the differences to, say, medication about that. So I think there's quite a lot of work that needs to be done. And I think the state of the evidence for arguably the most important, or one of the most important disorders globally, is not great at the moment for young people. And we need to improve in that. We obviously need good trials more generally and more funding. But I'm preaching to the converted, as it were. So that's my talk for today, and I'd be delighted to discuss this further. Thank you very much. Cool. Shall I stop sharing?
Yes, I think so.
Great.
Brilliant. I mean, thank you so much. That was such an interesting and thought-provoking talk. We've had a couple of questions through already. Please, people in the audience, do post your questions in the Q&A box that should be at the bottom of your Zoom screen, and I'm sure that Professor Stringaris will do his best to answer them, and hopefully we can have a good discussion. So I'll read them out for you so that everyone can see. So first we've got a comment by Professor Fran Rice. So she says, fantastic, fascinating talk. Thank you, Argyris. I think we'll all agree. So she says, RE active controls. How convinced can we be that well-matched active controls in psychological therapy are possible without deception or contamination of the active ingredients? And also, even with treatment as usual comparisons, many psychological interventions are effective, but they don't show strong effects. So do you think there's a place for personalization or understanding heterogeneity?
Yeah, I actually think that it is possible. Like I mentioned the example, at least in some areas, I mentioned the example of cognitive therapy versus behavioral therapy. Some of the trials that, amongst other people, Professor David Clark had done on social anxiety. So I think it's not impossible, at least in some cases. And if there is an active ingredient, surely you could compare one active ingredient to another. Well, that's what we do with medication. So I think it can be done. But you're right that even with treatment as usual comparisons, the effects maybe not be as strong as we've seen. And yeah, heterogeneity is the word, but I think it'd be great to understand the heterogeneity, but part of the problem is that in order to understand the heterogeneity of treatment response, you would need lots of people who have been exposed to the treatment. And ideally, you would need the randomization as well. So it's a catch-22 that in order to get there, right, to draw those inferences, you would need to do the trials. I've seen Professor Thapar's question next, which is about other designs. So maybe I can continue my answer to Fran when I respond to Anita's question as well. Is that all right? Do you want to read out Anita's question? Do you want me to?
Yeah, I'll read out Anita. So Professor Thapar says, great talk, of course. So she was wondering two things. So first, how realistic is it that we're going to get truly representative groups in RCTs in psychiatry? How important is it to use other designs? And secondly, the focus on fluoxetine evidence. So how much is that because that is what more trials have focused on in terms of medications, and as much as there's a much broader set of medications in grown-ups?
Yeah, well, I should say that I was quite anxious about this talk because I know how good the people in Cardiff are, and I was particularly anxious that I would get a question by Professor Thapar. So, but I'll try to answer this one. Yeah, it may not be that easy actually to get representative groups in RCTs and psychiatry, but this is also our own problem in a way. If we were as effective as the oncologists have been to put everyone into a trial, or everyone with a above a certain degree of severity into a trial, like they do that with leukemias, for example, everyone goes into a trial. If you're a child, you're not getting treated out of protocol. So if we did this and convinced policymakers that it shouldn't be the Wild West where you go to CAMS A versus CAM B, and CAMS B, and the differences in treatment are quite dramatic, and they should be in a protocol and an RCT, then I think we might be able to overcome this. But it sounds much easier than it is. And that's not because of our colleagues, but because the incentives are not there and everything. But I couldn't agree more. I think I tried to make the point, probably not very clearly at the last slide, that other designs are going to be very important until we get to those oncology-like trials or universal enrollments. I think we'll definitely need other designs, and if we can use prescription data appropriately and designs that emulate RCTs, I think that will be very good. And that's also an answer to what Professor Rice said. If we can use such designs, then we might also start being able to use the predictors from these designs. An example of this is the IAPT data, and I have a different talk now because we have some new IAPT data, but this is of course only for psychological therapies. But IAPT, or they're called now talking therapies. I've forgotten what their current name is. Is another kind of good nationwide kind of service where we can get such data, and so that's a good idea, and other designs would be very good. In terms of fluoxetine, yeah, that's a fantastic question. I would add here that fluoxetine, like the other SRIs, also work in depression. The other SRIs also work in anxiety disorders in this age group, in the same way they work for depression and anxiety in the adults. So there's this puzzle of fluoxetine, which is pretty similar in its action to the other SRIs. The difference maybe of its half-life works, but the others don't work. And all of them work for anxiety, but they don't work for depression. And of course, the answer is the placebo response, right? And the placebo response is fairly similar across the SRIs. And I think what saves placebo, and I should show the empirical data on this just to convince you and convince myself that I remember correctly, is the fact that fluoxetine has had the luck of not being funded in some of its trials by industry, but by the NIH. And therefore, there didn't need to be 52 sites involved, and the placebo response was smaller. And hence, when you do the meta-analysis, the differentiation is better. Does that make sense? So industry funding, more sites, bigger placebo response. Most SRIs didn't benefit, I think, from having those one or two NIH-funded trials, and they showed a much lower placebo response. And there's probably something about depression in particular that has a higher placebo in young people, that has a higher placebo response than anxiety disorders, because in anxiety disorders, I think the placebo response is around 30%, maybe 32, 35, but in depression, it's substantially higher, obviously. So I think that may be it. That may be it. Yeah. Yeah. I hope this answers the question. And then there are a couple more questions. You're reading them, Dr. England, right? Yeah.
I can do. You can read them if you want.
Oh, yeah. Okay. This is from Dr. Alex Lauzou. Psychotherapy controls, even if active and seemingly well matched, for example, behavior versus cognitive therapies, there's often great level of supervisions. For example, for the cognitive arms, as run by developers of the intervention with high level. Yeah, of course. Is that an issue for understanding? Yeah, of course, 100%. And this is another reason I didn't bring this up today. We are very rightly suspicious of industry funding trials. As I said, the problem is the opposite in child and adolescent trials than in adults, partly because child and adolescent trials are done because you get an extension of the license. I mean, the incentive structure is different. We can talk about that if you like, but we're generally, quite rightly, very suspicious of the pharma industry coming and telling us, it's a great drug. You wouldn't say, oh, yeah, do you say so? Okay, I'm buying it. I'm not saying that people in the pharma industry are evil, quite the opposite. They're fantastic people. They're often colleagues, and it's very necessary work that they do. But we're rightly, because we know how this is, we're rightly kind of thinking, okay, well, maybe not. Well, we should similarly be skeptical when the main results of a treatment come from one person who developed a particular treatment, and very often you will see that it is so and so's CBT or so and so's CBT, and often the people who develop the CBT conduct the trials. So I couldn't agree more with you. Yes, and so you would ask for replication, real world replication, and all these things. Like, it's different if you are running a trial. It's different if you're running a trial of an out of patent drug like fluoxetine versus my favorite new CBT that I've been developing for the last 10 years. Now the Professor Collishaw, hi Stefan. Do you think spontaneous remission regression to the mean will vary according to baseline severity, and thus at least in part explain? Yeah, well, I've looked into that. I've got these analyses. So basically, if you are worried about, well, you can do this for regression to the mean, right? But the analytical way of dealing with the regression. So, and this is one of the reasons what Professor Collishaw says here. This is one of the reasons why it's naughty to take things out of the randomization, right? But you can deal with it analytically by essentially running an ANCOVA, whereby you have your outcome and you regress you regress the baseline severity on it as well, if you see what I mean, right? So you take baseline severity into account. So we've done that, and the differences are exactly the same, if you see what I mean. So it isn't. We were worried about that precisely because of that. So we did a couple of things. We looked at trials where the severity was the same, but then also we ran this ANCOVA essentially and did this. Yeah. I hope this answers it, Stefan. So thank you for the question. Professor Thapper says, thanks for great answers. Funding source and its impact. Yeah, thank you. Yeah, I'm glad you agree. Then an anonymous attendee says, I don't know if this controversial question, but looking at the data, I wondered if there's any research on using placebo as treatment and maybe the acceptability. Yes, there is actually, and it is very interesting. It's the elephant in the room, in fact. It's like, we should definitely be doing more placebo. And there's someone at Harvard who has done some stuff in smaller trials. His name is Joe Kosofsky, and the people who work around him and with him. And you can look him up. I'm also happy to send you some papers. I've become very interested in this. This is one of my favorite papers is from the 70s, where they got weightlifters. They told them they would inject them with steroids, and it was the 70s, so it was and they did the unethical thing to inject them with, not inject them with steroids, but inject them with saline, but there was a dramatic increase both in strength and in bulk size in those who were injected and believed that they were getting steroids, and that was clearly a placebo effect with very kind of physical effects. You get the same thing in other areas of medicine. Like, people think that these are phenomena that are specific to psychiatry, but they're not. If you look at the hypertension trials, for example, there's big placebo effects. So yes, it should be used and exploited. And people have, Joe Kosofsky, when I last spoke with him, which is a few years back, he said, yeah, we've even just done a trial where we told them that we're going to give you placebo. And it worked. I haven't looked at the data myself, but so there are a number of things. I would put it in a more general way. I'm very interested in what we call expectations and prediction errors, surprises. So the way we form expectations is both philosophically, neurobiologically, and practically very interesting. And very often, everything in life, as they say, is about expectations and managing them. So I think that's true also of this. Another question by Fran. Hi, Argyris, please ignore if there are lots of other questions, but to ask again about the active. From the newest studies using near-RCT designs aim to pull out active or psychological in depressed adults point to common non-specific effects. So that does make a little worried about the feasibility. Yeah, no, true. Exactly, but if it's non-specific effects, then you might not need to train people in CBT, if you see what I mean. Like, for depression, at least, they might need different skills. It might not need to be that expensive. Like, if the active ingredient is generic, which it may be, because all sorts of treatments seem to work, then why not, if you see what I mean. Based on the informative, thank you, what does this mean for the stratification between antidepressants in terms of efficacy? Is fluoxetine the front runner, and that's all to say, or are other agents helpful? The comparison of psychotherapy with the associated control seems to, due to lower SMDs, only beneficial for a less severe form of depression, whereas the SMDs are greater for medication, hence better for increased severity. I know I wouldn't draw this inference from what I presented. That's when I would be naughty if I told you to draw this inference from the data the way I presented them. There is a debate, as you may know, about whether baseline severity is important or not, and that's in adult data where we have lots of data and seems unresolved. Some people will say it's resolved, maybe not, but I don't know. So no, I wouldn't stratify by that. I would tell you that the way I do it is I follow Tordia. So but I start with fluoxetine, and if it doesn't work, then I go to another SRI, not using paroxetine, either sertraline or escitalopram, or citalopram rather. If that helps. And then Dr. Hina Kanwal, hi, thanks, Argyris. I don't know whether there's more to come. Oh yeah, might it be relevant? What do you think about astrocyte role in anxiety problems? I don't know is the answer. Sorry, I don't. I've heard about the role of glial cells in this, but I'm not an expert. I don't know enough, I'm afraid. I'm sorry about this. But it's good, interesting you raise the point of anxiety, because I think anxiety is more treatable. Another kind of obsession I've had over the last few years is maybe we should just treat the anxiety and not worry initially about the depression. And this may be very radical. And obviously you're not going to do this in people who are catatonic, but in a lot of the depression and anxiety we see, it may be worth caring about the anxiety first, because that's something very circumscribed. And often in clinical experience, for what that's worth, treating people's anxiety improves the depression as well. And I'm working on data now to show that this is true also empirically as much as I can. So I think that we often ignore the issue of anxiety and treat anxiety and depression as if they're two completely different entities, which of course we know they're not, certainly not in our clinics. I don't think there are other questions.
No, I think that's perfectly timed, actually. That makes my job as chair exceptionally easy. But so I would like, obviously, to thank you very much, Argyris, for speaking. That was an absolutely excellent talk. Really interesting discussion, I think. Thank you so much, to everyone who came and participated. Just a reminder to everyone listening that the next Wolfson public lecture is going to be by Professor Vikram Patel. It's going to be on Thursday, the 16th of May, and we're going to be discussing school interventions for promoting adolescent mental health with a case study from India, and I hope to see all of you there. And just once more, to thank Professor Stringaris for coming and giving such an excellent thought-provoking.
Thank you very much for inviting me.
Thank you, everyone.